Hello and welcome to the second live surgery done during the third Max Live Robotic Prostatectomy Workshop. I'm Dr. Tushar Aditya Narain and I'll be doing the surgery, and my moderators are Dr. Ashwin Sridhar, Dr. Rahul Jaina, Dr. Madhav Tiwari, Dr. Kinju Adhikari and Dr. Harkirat Singh Talwar. So thankfully we have the outside shots also of port placement. So we'll begin with the port placement. We generally place the first port, the camera port, 3 centimeters above the umbilicus, and we place it through an open technique because this is where we extract the specimen from. We don't use a Viris needle. We open the sheath, incise the sheath with the scalpel and puncture the peritoneum with the finger. It's a blunt puncture, so very less chances of injury to the bowel. Once our fingers are in, we'll put the first port in, which is the 8mm camera port. And because the incision is a little bigger, we'll use a figure of 8 Vesicle suture to make it airtight. So that's the first port going in. We will connect the CO2 tubing. The initial pressures are at the set pressure is at 20 because we need to insufflate it more for the ports to go in. So the initial pressure is 20. Once all the ports are in, we get it down to 10 or 12. Till the pneumo is going up, we'll use a 10 Vesicle suture to close the incision that we made to make it airtight. Once the first port is placed, we put the camera in, see if everything is fine inside, and then before placing the rest of the ports, we put the tab block, that's transverse abdominis plane block, on each side, which we'll just show. We prepare the tab block by mixing 20 ml of 0.25 bupivacaine and 20 ml of 0.5. That makes 40 ml of 0.375 bupivacaine, of which 20 ml we inject on each side. The site where we inject, that's just below the costal margin, and the plane would be between the internal and the transversus abdominis muscle. You can see on the outside, we'll take the syringe, 20 ml of that, go in, and through laparoscopic camera visualization, see the needle, do not puncture the peritoneum, and then retract the needle and then inject the saline and the bupivacaine. If it's in the right plane, a bleb of muscle will rise up. If it's in the preperitoneal plane, just the peritoneum bleb will rise up, the muscle bleb will not rise. And if it's between the external and internal plane, no bleb will form. So you can see that the bleb coming up, and you can see the muscle on the bleb. So it's in the right plane, 20 ml going in between the transversus and internal, and this gives excellent pain relief in the post-operative period. Then we go on to the ports on the left side, 2 ports on the left side. The first port is 8 centimeters away, 8mm port through which the Maryland would go in. So that's the left hand port. Once that's done, 8 centimeter further lateral in the same line, that's all in the line of the umbilicus, and that's again an 8mm port. For cystectomies, we put a 12mm robotic port because we need a sure form in there, but in prostates, we use this as an 8mm port for the progress to come in. Now the tab block on the right side, similarly on the right side, you would see the bleb going up. First the needle comes in and then the bleb goes up. You can see that in the bupivacaine being injected. 20 ml of this goes in, and then the rest of the port. The first port is the right side, 8 centimeters away at the level of the umbilicus, through which the hot shears or the monopolar scissors would go in. Apart from this, I generally use 2 ports, 2 assistant ports. One is a 12mm port just above the ASIS, that's for the hemolocks and the sutures to come in. And apart from that, another 5mm port between the camera and the scissors port. That's the 5mm port coming in. Now once all the ports are in, we are ready to dock the robot, the Da Vinci. This was the Da Vinci X robot. We first take the operating table all the way down, and then we'll put in a head low position. The head low would be about 25 degrees head low. so that all the bowel comes out of the pelvis and the prostate is sitting right in front of us. So once the table is down, now the head low position is done so that the bowel falls out. You can appreciate the ports better. All the ports are in a straight line except the camera port, which is about 3 to 4 centimeters above the umbilicus. And now your assistant is ready to get the robot in. The robot comes in. This is an X, so it's coming in between the legs. If it's an XI, it can come from the side and the boom can rotate. And with this, we'll go on to the intra-abdominal view, the robotic view, and we would have the live discussion that happened during the surgery, during the second surgery of the third Max Robotic Prostatectomy Workshop.
Starting the second case. Tushar, you're going to start with the posterior approach, yeah?
Yeah, so probably the last time I did a posterior approach was in the last conference with PS, and after that, during training, when I go for training, the surgeons do a posterior approach, but I don't do it. So we'll start with the posterior approach.
So what are your landmarks for your posterior incision then?
So my assistant would come in, my assistant would get the sigmoid out. There's no sigmoid adhesions here, or else I would have gone ahead with the sigmoid adhesiolisis. So this looks pretty good. So this is where the rectum is. So I would go about a centimeter up here, and I feel this is where the SV or the vas would be. My progress would lift the bladder up. With my other arm, I will hold the peritoneum, pull it down, and then make a horizontal incision where I feel the SV and the vas are about 1 centimeter above the reflection. And then sweep up.
I think it's very important to sort of go along the peritoneum here, isn't it? Because otherwise you end up, if you're too high up, you end up going into bladder.
So I think I'm holding it a little higher up, so I'll reposition my progress, come down.
You're in the perfect plane.
And I'll try and open it here.
Yeah, there you go.
So that's my SV. So I'll go just beneath my SV and sweep things up. I won't push down because behind is just the rectum. This is the peritoneum and behind this is the rectum. So I'll sweep up. I did a DRE right now. It's a nodular prostate, bilateral nodules felt, and his sigmoid also, and rectum was full of stools, so I just hope they don't decrease the space.
Do you do any kind of,
Sorry?
variation of bowel preparation?
So no, we don't do bowel preparation. So if it's a salvage case, and if I feel it's absolutely stuck, I give an enema, and bowel preparation with peg leg I've never done. So
No, so any variation of preparation. It may not be enema.
No,
You give
just
them
just
Dicolax
enema. Enema if I feel it's gonna be stuck.
I have started giving them Dulcolax depending on how heavy they are, because I feel most Indians are constipated, whether they know it or not.
Okay.
And I think post-operatively they just feel a little lighter.
Yeah.
Right. Okay. That's a good point.
Because you're going to pump in all this gas and they're not going to, have a good bowel movement for a few days. So at least, I mean, that's my opinion on it.
So that's the vas.
Yeah.
So now I'll walk on the vas, skeletonize the vas.
Yes. Yes.
So that's the difference. Here you can see it is horizontal. When you do a completely anterior approach, it was vertical. So it's not so important to dissect medially as it's laterally. Thank you, Praveen.
Yeah, absolutely. I mean, I think the question was, I think in the sessions we had, are you not afraid of ureteric injury at the bladder neck? And the answer is, it's not at the bladder neck, it's here. If you go too lateral at this point, you're then going beyond the SV and too high up, then that's where you go into.
So thanks, Ashwin. So I'll again show you what mistake I had done when I was doing that, and I was about to divide the vas, and then I stopped because I remember the teaching of another of my teachers. And PS, he says, till the time you see the other vas, don't divide, because ureters won't meet in the midline, the vas meets in the midline. So I was about to divide that vas, but I stopped. I'll just see if I find the other vas also meeting in the midline, and then I'll divide that.
I am sharing the same experience with me also, in which one of the ureter was transected almost, and the patient had a lot of drainage, and he was in anuria, and other ureter was also clipped. So fortunately, we could remove that clip and put a DJ stent, and where it was injured, there we did we did a Boris flap. It is now long back, 8-9 years old. So we made a Boris flap and reimplanted that ureter.
So it's a similar instance in our department as well. So we saw the ureter, it was half transected. So we could see the urine coming out, fortunately. So we were able to identify it, and later then we reimplanted.
And the worst part was this patient was a lawyer of London. Thankfully, he didn't sue my boss and the NHS. But it was only on post-op day 1 in urea for 24 hours. And I had clipped it on both sides. Not one. But thankfully I had not divided. Yeah. I don't know how I stopped myself from dividing. Generally you clip a pedicle and then you divide it. No sir, metal clip. Oh, you were using, yeah, so it would divide with that, yeah. So this is the other vas. So now I'm sure these two are meeting in the midline, and this is the SV also. So I can go back to the right side and divide it. So I'm actually doing this step after a year. Because in bladders, we go beneath it, we don't dissect this vas out.
So one is we see the tip of the SV and we go up to the...
Yeah, we'll see the SV.
So the teaching that we have is, what we teach our fellows is, cut the vas at the second genu and don't go so laterally. If we tend to go laterally, that's where we will find the ureters.
So one of the consultants I worked with, when he had a high-risk case or something which was a bit locally advanced where you didn't have to do this degree of nerve spare, what he used to do is visualize the tip of the SV, then take an instrument and kind of encircle the pedicle going to the SV, and the entire thing in a bunch, you would just put a clip and lift it up. So
clip लगाएगा कैसे काटे? हैं?
No, that was something which Ashwin was saying that we shouldn't be doing it. But if you don't hope to do a very good nerve spare, that would just be something.
One is SV wave, that you identify where we should divide was. Any other landmark?
Yeah, I'll show you to prevent the ureteric injury, right? Yeah. Yes. So the main thing I learned from my mistake was walk along the SV. Don't go away from the SV. Be on the surface of the SV. I was very far away from the SV when I was. Ureter will not come here. Ureter will come here. If I dissect here, I will find ureter here. I'll think it to be a pedicle. But if you work here, ureter will not come here. Hopefully. Ashwin, any inputs on that?
Yeah, no, absolutely. I think you're absolutely right. So it's all about staying on the seminal vesicle. So even if you want to sort of pedicalize and take the SV pedicle, you don't sort of hook and sort of take it. You want to be exactly on the surface and take the pedicle rather than anything else. Because you go any further away from the SV and then the ureter is right there, especially in relatively
Thin patients, yeah.
Tushar, if you were going to do a nerve spare in this case, at what point?
Clips, all clips. Tip of the SV has maximal nerves here. So I would clip all of it. I will not use any cautery.
So what is your landmark to start the clips when you approach posteriorly?
So the first few fibers that I buzzed here, I would not use any cautery here. Once I've gone beyond the bulb of the SV, at the base of the SV, I'll start using cautery.
Seminal vesicles, you are not using cautery.
Yeah. Last year.
Oh, you are using
Can
cautery.
we have a camera clean, please?
Okay,
We have a smudge here.
Sure. Let's do a camera clean
So,
quick.
if you like you're saying, if you have this repeated camera smudge on the, I don't know if it's on the X, it is definitely on the XI. There is something called 2X zoom in your settings. The vision quality goes down by ever so slightly, but you are further away, so you don't get that smudge.
Metal clip hai? Okay. So if I'm doing a nerve spare, get the metal clip.
If you're doing if you're not recording the case for a presentation or something, then that is very nice.
Abey yaar. Allow hemolock lock. So if you're doing a nerve spare, I use metal clips. Metal clips is not ready, so he's putting a hemolock where we would put a or close. Chalo, theek hai, laga do. So no cautery, hemolocks and cold cut like this, and stay on the surface of the SV. And once the bulb is out, then bulb is up, then you can use cautery here because there are no nerves near the base of the SV.
The least amount of local inflammatory reaction. Luprolide will have the highest.
Last time on the conference in the workshop, PS Prasanna Suryakamaran was here. I was again demonstrating this posterior. He took the cautery wire out while I was doing this. So even if I wanted, I couldn't do cautery. Praveen would remember.
I won't be nasty like that to you.
Yeah, he was very nice.
Well, you worked with him for more than 12 months.
12 months, yeah.
And survived. I think you have a record at UCLH, working with PS for so long.
Time will come.
So on DRE, I think that I felt it was almost a T3 disease. Nodules on both sides, both lobes jutting out.
No, and then also I think if you're unsure, you don't. That is my understanding of posterior dissection. What you don't divide them. Do both sides, because there can only be two structures going in the midline.
So that is done on one side. We'll go to the other side. थोड़ा धीरे बोलेंगे. Again, walk on the vas, along the vas. And that's the second curve here that Kinju was talking about. I'm going a little further away because I think it's a locally advanced disease. I don't want this to be positive. A lot of times this end comes as positive.
So, question to Tushar and Ashwin and Rahul. There's a question here that what is the extent of your posterior dissection?
So, ideally, we should go beneath the prostate again till the apex. But a lot of times, because I'm not used to this approach, it keeps falling down. So, I leave the posterior prostate dissection till I've done the bladder neck and then do the posterior dissection. But if I can easily go, I'll see if I can easily go, I think the plane is opening up. So, we'll go to, till the apex.
Yeah, I think, I mean, when I do the posterior section, I sort of go all the way to the apex, like Tushar says, and I go interfascial. I think you just saw him opening the fascia there. I think that would be ideal for him to go.
इधर clip लगाएंगे, बड़े-बड़े veins हैं. Metal clip आ गया? So no, I just wanted to show when if you're doing a nerve spare, this is the area where you would want to clip because it's the tip of the SV. You would all the vessels come here. So here, like लिया है, ठीक है, लगा दो. Yeah, नीचे 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 एक vessel ये छूट रहा है. Yeah, perfect. Thank you. Cold cut. Suction. Again, another pedicle here. Denonvillia stuck to the SV. You can see here, that's the denonvillia. Thank you. Mobilize the whole of the SV. Sometimes what mistake we do is we extra mobilize so that the SV comes out in our hands. So we need to know where to stop. I think we are reaching the prostate. Again, it's all stuck here. So we'll not go any further. I think this is a case exactly opposite to what we saw in the morning. This is the SV. Because it's stuck, it's not coming off. I'll have to cut with a cautery. This is SV, so I need to go beneath it.
I think that gap underneath there, your scissors, that's perfect for you to do that posterior section.
So what I'll do is, एक मिनट पहले इसको ले लेते हैं, अंटीरा कर लेते हैं. This is the bladder now coming in, so we'll stop here. We'll go to the posterior dissection. Yeah, this is the. I'll ask my assistant to hold one, the right side, and pull it to the right shoulder. I will, with my left hand, hold this one, pull it to the left shoulder. My assistant will pull to the right shoulder, and I'll try if I can go down. Suck, please. Money.
Yeah, I think you've got a nice interfascial plane just below you there. Yeah, that one there.
Suck, suck, suck.
That's it.
So question to Ashwin, does it make a difference if in the midline you are extrafascial and then you go intrafascial laterally?
Yeah, no, I think absolutely not. I think I would prefer to be interfascial in the midline and erring on the side of extrafascial. I would never go intrafascial in the midline, and then I always break back into the right plane that I need to go.
The rectum is tethered up a little, the fat is coming up. I think this is an extrafacial plane. I'll try to pull this down because see the rectum, the fat is tethered up. Generally the fat goes down. Yeah, so this is a better plane because I see a layer of fascia below. So I cannot see the fat there. So this is the interfacial plane. Again, the rectum is very near. Thin patient. Sucker. Your assistant will pull the rectum down, yes. With your Maryland, lift the prostate up, and with the scissor, not the tip, the base of the scissor, try to get the rectum off the prostate. Does this look okay, Ashwin?
Yeah, I mean, it looks beautiful. I think you can see the sort of the ventral venous complex at the apex. So I think your apex is pretty much done.
Yeah, it's a 20 cc prostate, it's a small prostate. It's important to do this on the sides also, because later it will be easy. The Denon-Villiers is down, the rectum is down. So when I did a rectal exam, I was scared of the rectum right now, but I think it looks okay. Okay. Yes, please, sir. Gauze piece, camera clean.
Yeah.
If at this step you find some leakage of urine is happening,
Okay.
how will you proceed then?
Sir, I'll trace both the ureters first.
Well, on with the robot only?
Yes, sir.
Okay.
Yahan pe we'll open the peritoneum, trace the
Okay.
ureter completely inside.
Acha.
Gauze piece, please. Gauze piece. I think I'll stop posteriorly there.
Yeah, I think you're pretty much done.
We've reached the apex. We'll get a camera clean quick, and then we'll go on with the bladder drop.
I have seen this very complication happen in the OT.
Mic, on the mic. On the mic. Jinam, please, mic.
Exactly whatever Tushar said, वैसे ही हमने किया.
Like you open the
नहीं open नहीं ऐसे side में
Yeah.
हाँ.
Mic में बोल रहा है वहाँ. So everyone, please, Jena, others in the hall cannot hear you, so speak on the mic, please.
So how did you manage that time, na? Like if you have a leakage and you know it is a partial ureteric injury.
Yeah, it was quite a big rent.
It is a big rent.
So they placed a guide wire and just threaded a stent over it.
Then cystoscopically.
No.
From above.
Yeah. So it was a rent longitudinally.
Okay.
They put in a guide wire, put one end inside the bladder, put a stent over it, just like we would do in a open surgery or a laparoscopic surgery. And the stent
So
was
with
left
that
inside for 3 weeks time.
so that's the Foley's catheter.
And retrograde pyelogram and all, CT urogram was done.
So dropping the bladder, Ashwin already told us the landmarks. So I'll just repeat it for everyone else. So I hold the medial umbilical ligament, the right medial umbilical ligament, just above the crossing of the vas. This is the gonadal vessels vas, crossing of the vas, and pull it to the opposite side. He has a hernia, so I'll hold a little higher up. And then just parallel to the medial umbilical ligament, I will incise the peritoneum. Incising single blade, just the peritoneum. And this incision will go down till the vas. Cutting is with one blade, as Ashwin also said in the morning. If you have to coagulate, point coagulation, double blade. But cutting, where there is no vessels, single blade and a traction will open everything up. Till you see the vas. This is the vas. We've reached here, so we'll stop here. And now we have to stay in this avascular plane. Adjust your fourth arm a little if needed.
We even coined a term for this
Angel
technique
head.
where we keep the urachus intact. We called it anterior Retzier's pair, although technically it's not that because the radius space just reconstruct itself by going and sticking, the bladder goes and sticks to the wall. But you're cutting all the other things which you would normally not do if you would do a proper radius sparing surgery.
So I think this is the hernia. So the important thing is here two things. Stay in this avascular plane. And the second one is to go down and not straight. Your lighthouse is this bone. Once you've seen the bone, you have to stay medial to the bone. Lateral, you would get all the vessels. Medial, you'll not get anything. And it opens up completely. So you have to stay beneath and medial to the bone. So this is my bone here. I've gone medial to the bone and go down till the endopelvic fascias.
So Dr. Tushar, Dr. Sarbarta here.
Sir, hi. Hi, Dr. Sarbarta.
Hi, sir.
Good, good. Welcome.
Yeah, thank you. So you do, in your work cases, I have been seeing completely anterior approach.
Yes.
So in this case, you are doing combined approach for the demonstration.
Yes, demonstration. Yes, 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 yes. Because Ashwin in the morning showed a completely anterior approach. So this is the periprostatic fascia going on to the levator muscle, levator fascia, go down to the endopelvic muscle. Dr. Sarbarta is again from Rajiv Gandhi. We had Dr. Ashish Khanna in the morning from Rajiv Gandhi.
Thanks, sir. So in this step, sometimes we encounter some vessels which is called corona mortis, just below the Cooper's.
Yes.
How do you manage this? Does this bother you?
Try to avoid it. If it starts bleeding, I'll just buzz them. And I think bipolar generally is enough to stop them. We have to see what we have to do for this hernia.
I think you're doing the right thing by releasing the hernial sac. So if the hernial sac is not open, then usually you're safe.
I think we've crossed the midline. That's the pubic bone in the center.
Yeah.
So we've gone to the other side. I always almost drop the bladder because I'm not as efficient as Ashwin, so I will not let it hanging up. And I think Praveen also did a good job in the morning. He's also not used to the bladder hanging up, but he could assist well in the morning. So once that's done, you'll make sure you've dropped everything till the top. So it's still remaining a little. So I'll open this a little more before I go on to the left side. Again, the avascular plane. I'm not entering into the anterior abdominal wall. I'm not entering into the fat of the bladder.
Tushar, can we drop it little bit lower down?
Yeah, we can drop it here. No, we can drop it here. In cystectomies, we have to go up. Here, we can drop it here, so no problem.
Okay.
No problem.
No, but then you would have that hanging in your face.
So if we leave a lot of thing on the top, then it will be as hanging in front of the camera. I think that's enough. We'll go to the opposite side. Either you can pull it or get your assistant to pull it. And again, with a single blade, just open the peritoneum. The pneumo will do all the work for you.
So, sir, while doing this step, do you ever felt lost how much lateral you have to go? Because
So
what I do, I initially do the paravesical space first, then drop this bladder. So that keeps me reminding how much lateral you have to go.
Yes, so I follow this medial umbilical ligament, so I'm always parallel to this medial umbilical ligament. And because he has a hernia here, it's a little confusing, or else it just opens up, joins the space on the other side.
Yeah. And how much you drop the bladder for the adequate exposure? Till the vas?
Till the vas, the vas, and sometimes slightly along the vas also I drop a little, but we'll see. So till the vas at least.
Yeah.
So this is tearing it here. I'll leave it, just bipolar it once. When you bipolar, if the jaws are completely closed, it won't work because it will short circuit. So you have to keep the jaws a little slightly opened. And when you think you're ready to drop the bladder, hold both these together, pull it down. I'll just open this a little more.
So, Dr. Tushar, you always take Maryland bipolar in your left hand,
so
or
for pelvic surgeries, prostate and bladder, I take Maryland. For kidney surgeries, I take fenestrated bipolar.
Okay.
Because I like the curve for the pelvic surgery, for the prostate nerve sparing and all. In the morning, Ashwin showed very well how it sits on the curve of the prostate, retracts the prostate, and the nerves can all be separated out.
And I think the fine tip helps also in dissecting the planes.
Yes, absolutely.
Yeah. But do you think the fenestrated bipolar is more sturdy than this Maryland bipolar?
It's very big for the pelvis, I feel, because pelvis is a narrow space, and when doing the nerve spare, separating the nerves, I find that instrument very bulky. It's said obliterated, but most of the times it has patent vessels and it bleeds. So you should bipolar it on the top and the bottom, and in the midline also. See, most of the times there's a vessel which bleeds, so you should always bipolar. It's said obliterated, median obliterated umbilical ligament, but it's always patent.
So I think one of the important key step in this bladder drop, which is the easiest step in the radical prostatectomy, is not to enter the bladder and keep a fine layer below the rectus muscle. If you can see the rectus muscle, then you are in the wrong plane.
Yeah, true, absolutely.
I mean, if you're seeing muscle and follow it, it usually takes you above the pubis into the groin. So it's quite a telltale.
In patients who are chubbier, that's a problem, because there's a lot of fat. So in some patients you'll be able to see the muscle directly, you're in the right plane, but in chubby patients you tend to go above that. So what Ashwin showed in the morning is actually a very nice way of doing it. You give a lot of traction to the opposite side and you'll see a plane of the peritoneum all thinned out. If you just poke at it and make a hole, the air rushes in and separates the tissue in the right plane. So your chances of entering into the abdominal wall become less.
Some big veins here.
As long as your vision is right, you just keep on going from one side, so that in the other side is just a thin film of peritoneum, and you incise it and the bladder drops down.
Again, the trick here is just remain beneath the bone and drop everything medially. Hello. Hi, Harkut. Yeah. On top of the vein. So I'll just do this and let's go. I'll go. So that's something which shouldn't be done. So I went a little deep. So that's DVC bleeding. So there's a superficial dorsal vein which should be bipolar. I've touched the DVC, so it will keep bleeding now. I don't know how I'll stop this. Let's see. So this is a rookie mistake which should not have been done. Okay. So let's go here. So how much should we drop the bladder? So I generally drop it till the level of the vas. I'll drop a little more. And because it also depends on the prostate size. This prostate is very small, so I think this much should be enough. I see the prostate turning back here, so I think we are good with the bladder drop. This DVC will keep troubling me now.
And if you have planned to do a lymph node dissection later, would that help if you do it
yes,
right now?
Yes, it will help me later. Pressure को थोड़ी देर 15 कर दिया जब तक निकाल नहीं देते हैं prostate. ठीक, thank you. आई ये कहाँ से आ गया? Okay. So now the next step is defatting the prostate. So while defatting, that's what happens if you are very close to the prostate and touch the DVC. So it should be in the air and sweep off the fat of the prostate like brooming. It's a little stuck here. Probably it's involved. Yeah. Out.
Another thing we encountered is the accessory vessels. How
Yes.
frequently do you encounter them? And
So I would say
any
10%
tips?
of the times we get an accessory pudendal going from here. Try and save it because that goes to the penis. So if it's here, I'll just sweep it laterally and lateralize it so it doesn't come in my field. Now what next I do is open the endopelvics here. One layer on the prostate, I sweep so that this layer goes onto the muscle. I don't cut it with cautery, I just sweep it. Because it's a locally advanced disease, so I think it's a little stuck here. The muscle fiber shouldn't be bare as this is, but it's stuck here.
What is the trick, Tushar?
So sweeping
Of
movement,
this-
just
this-
retract the prostate like this. And
At what place?
at the base of the prostate, where you feel the base is there. You just need to see the base. And you should visualize this fat. This is the prerectal fat.
Okay.
So this, once it's visible, that means you've sweeped it enough.
Okay.
Because I'm not doing a nerve spare, I have completely sweeped it away.
Can we use the forearm to retract the prostate?
So this is designed for this. I think this is a better plane. So this is a better plane, which I couldn't get off. So this is the plane, this layer going onto the muscle. See, this is the levator muscle fascia.
Right.
So this should go onto the lateral thing.
Yeah, right.
This was stuck to the prostate, hence I couldn't, but I finally found it. And there's one layer on the prostate, and this is the prerectal fat. This fascia should go laterally. This is what the view that you should have of the fat. फैट भी थोड़ा निकाल लेना. Yep, biopsy. Yes, as a separate. All the cases as a standard.
In how many cases it is positive, Tushar?
सर अभी दो केस में मुझे पॉजिटिव लिम्फ नोड्स मिले हैं इसमें out of about 200.
200.
So 1%. And it was positive with a lymph node, not direct lymph node, yeah.
Does it make a difference in your future planning?
So, I don't think so, sir. So if there are 2-3 lymph nodes here, again it's all stuck. 2-3 lymph nodes, then probably we can think of adjuvant hormone therapy.
Or you follow up with the PSA, or you can start? You have to
PSA.
start.
No, I would. So if it's T3B or an N1, N2, then probably I would start hormone therapy, sir. If it's just T3,
without PSA even estimation?
Yeah, probably, because I know it will come as positive. PSA would be high.
If the PSA is normal?
I generally start, sir. T3B I start. Because a few patients I had kept on PSA surveillance and realized 6 months later I would have to start them.
Okay.
So generally it just sweeps away.
So this would be a question to you. What difference does it make sweeping away from cutting it, considering you're using a cold cut and not a cautery? Does it make any difference? Yeah. Cutting versus sweeping away.
Yeah, I mean, I don't cut the endopelvic fascia, so I'm probably not the right person to ask. But Tushar, if you can just stop there just for a sec. You can see the nerve very nicely just along the muscle laterally there. I don't know if you can, do you have a...
This one?
Yeah, that's the nerve. So that's the nerve that sort of goes from the pelvic side wall all the way to the sphincter and helps sort of with continence and all of that. So that's why you probably don't want to use diathermy even if you do open it up. You can definitely cut it cold. I mean, most of my dissection is cold, so it really depends on what you're trying to achieve.
30 degree warm करके देना. 30 degree.
Because in sometimes locally advanced cases and post
30 degree. So I would just request all the discussion, do it on the mic so that people in the conference room also can hear.
Yeah, as your planes are good and you are swiping the endopelvic fascia, but very often we find that swiping is not possible at all. We have to cold cut it.
And I think the question on sort of the positive lymph node and the fat, so it is quite rare. I would say probably less than 5%, but I think it depends on your primary Gleason and the primary stage. So we would still consider it as N1 if it's actually a lymph node. But if it is, Gleason 8 with the N1, then I think they're heading to systemic therapy. If it's Gleason 7 with N1, then it could potentially be curative. So that's the ones that we would sort of watch and not give them any adjuvant treatment.
Right. So all the Gleasons.
Yeah. So Gleason 8, T3B, N1, he's going to go into hormones.
Dr. Vashin, what is your take on adjuvant RT versus hormone therapy? Like the index case you described, T3B, N1, Gleason 8.
So there is absolutely no evidence for adjuvant RT in prostate cancer, and I think the Radicals trial proved that quite well. But I think there is a place for persistent salvage RT, early salvage RT in persistent PSA. So I think if you want to give RT, if the patient is very fit and is amenable to RT, I would not start them on hormones. I would wait to see if they've got a detectable PSA. But if they've got an undetectable PSA, but it's still higher, you think it's going to trend, then just wait for it and then hit them full with hormones and RT.
Yeah.
That's Radicals.
That radical, yeah.
Wait till the continence is there?
Yes. Yes, I think that is one of the advantages of just giving them hormones before the RTs. You give them a few months to regain. I mean, radiotherapy messes with it anyway afterwards, but still, at least you can document that they were continent after prostatectomy and then they were incontinent.
Okay, so the next step is
take
bladder
a lot
neck.
of time to become continent, maybe 6 months, so you'll have to wait for 6 months to start a radiotherapy in these types of
And
patients.
this guy has a Gleason
So I think
4+4
what
disease
the
at the
evidence
base.
now is that as opposed to maybe 5 years ago when if we had a lot of margins positive or we had N1 disease, we used to start this patient on adjuvant treatment irrespective of what nadir PSA they achieved or whether that PSA actually went on to progress or not. But I think what Radical's RT has shown is that even if you do have positive margins, at some places you have a tumor which is upstage to T3, you don't have to hit them with adjuvant RT right away. You can just follow up these patients, and if these patients go on to develop biochemical recurrence or rising PSA, that is when you start them with early salvage radiotherapy rather than do adjuvant radiotherapy. So the situation which you are talking about where a patient is taking more than 6 months to be continent enough to get radiotherapy, I think that situation is quite rare to start with in UK where this trial was done. Chris Parker was the person who headed this trial.
So
there are
can
very
I
few
show
patients
the
who are
bladder
incontinent
neck?
beyond. Yeah.
So he has a basal disease, Gleason 4+4. So I'll not go very close to the prostate. Suck. But still, I'll try to preserve a decent bladder neck. I did a bimanual maneuver and I felt that this is the bladder neck here. And if I open here, I think I will get the urethra. But I'm just trying to, again, show what Ashwin showed in the morning so that you can understand better by seeing two surgeries. So stay in the fat. The fat is between the prostate and the bladder. This hand would retract the bladder and also would open up the fat. And these are the veins that go from the sides to the prostate. This would bleed. If it bleeds a lot, like this, it started bleeding. So sometimes I put a clip also here. Suck.
So Kinju and Madhav, the audience is unnaturally quiet. I believe it's because of the heavy lunch, or maybe you guys are answering all their questions and there are none for Tushar. I think they are asleep too.
Sir, question from the audience, like how to identify where is the bladder neck, like some tips and tricks.
Tushar, after you have done this step, do you want to do a bladder tug, catheter
do a
tug?
catheter tug. So there are 2-3 things to determine where the bladder neck would be. One was what I was doing, a bimanual palpation. Here my instruments won't come together because it's the prostate. I keep coming back. And here I feel it's coming, and the only thing in between is the catheter. So I think this is the urethra here. Suck once. So that is one method. The first thing which tells me where the bladder neck is the pre-prostatic fat. When I was removing the pre-prostatic fat, it's very easy. We were seeing it was just coming off the prostate. While when you come to the bladder, it becomes sticky, so it won't come off very easily. So that is one trick also to understand where the junction would be. And the third is a catheter bounce. So let's do a catheter bounce and see how it's coming along. Catheter bounce, please. Push it in and then bounce it. झटके से करना बेटा. So I think it's coming till here. फिर से एक बार करना, दिखाना, अंदर डालो, प्रवीण करना. So you see, this is the bladder. Karo. So it's coming in till here. So all of this is bladder. So I think this is the line of dissection. Can you differentiate? Prostate, bladder fiber. These vertical fibers are bladder fibers. And that's where we are dissecting.
Dr. Tushar,
Yes.
despite everything, all these maneuvers, still when you cut the bladder neck, you find out that it's not at the proper place.
Yes, that's fine, sir.
So what rectification will you do?
Nothing. Only thing is you can make it bigger. If you've cut into the prostate, come back. Cut here. You shouldn't be leaving prostate in the body. But if you've cut here, that's fine. It's a little bigger bladder neck. So smaller bladder neck preservation only help in a return of early continence. At 1 year down the line, it's almost the same. It was just that if it's a big bladder neck, you'll have to do a recon. So I think we've punch through वर्कपीस दिख रहा है?
Yeah.
So,
Left side.
so this is the SV. This is the fat, and this is the junction. This is the prostate, this is the bladder. If I keep cutting and coming on top, we would have done a circumferential bladder neck dissection. Are you happy with this, Ashwin?
Yeah, very good.
What my left hand is doing is retracting the bladder. So as soon as I'm touching, at the weakest point, it just opens up, and the weakest point is the junction. But I don't want to go very close because it's a Gleason 4 disease. So I'll come back from the midline. And I'll show the top-down approach. If we had not gone from the side, if we had just gone in the midline, this is how we do. So this I do. Ashwin was saying we shouldn't do it. He was absolutely right. It should be like this, attraction, and it opens up like a book. So you see the junction. This is where the prostate is. This is the bladder. And I'm trying to leave some fibers on the bladder so that we don't get a positive margin with Gleason 4 at the base. Suck. And when you've reached the urethra, you can sweep a little just to get an extra length, and I think this is the urethra, yeah. Balloon deflate, please. So this is the prostate, a thin layer of bladder fibers on the prostate. Thank you. This is a nice bladder neck. Now I take this up, my assistant would give a traction on the outside, and I will lift it up, and this lifts the whole of the prostate up. The next step, there are 2-3 things that you can do. You can put your instrument inside, pull it towards you, see everything clearly, and then cut across. You can go from here. Or you've already done this dissection, you can come from the back.
Again, my question, Tushar, if there is a big median lobe here?
Yeah, so come from the side, sir. If it's a median lobe like in the morning we saw, because if you're peeling it off, the median lobe will stay here, bladder will be peeled off. If you're coming from the front, the median lobe, we'll have to open the bladder neck a little more.
So there will be no chances of bladder thinning if you are doing it from the posterior side?
Sir, more chances of, sorry, what?
Bladder thinning. Maybe.
Bladder thinning, no, sir. Because when you're peeling it off, the whole of the bladder will be peeled off the prostate. Okay. So it won't thin.
So, sir, with this, what you're doing is you're protecting the bladder, and then you're trying to visualize the prostate. So because you're pulling the bladder behind, you will not go into the bladder. The only risk is going into the prostate. So as long as you have a film of bladder on the prostate, you're safe. And you're never going to go into the bladder because you're protecting that with traction posteriorly.
So this is the fat between the prostate and the bladder. So till the time I'm in the fat, I know I'm safe.
Yeah, I mean, my scissors are on my right hand. I'm right-handed, so I go right. But I mean, if you've got your scissors on your left hand, you can go from the left. We had a left-handed surgeon. I think he was probably after your time, Tushar.
No, I was there. He was the one who was doing transperineal robotic prostates, right?
No, with, were you there when Ruben was there?
No.
Yeah,
no.
I think Ruben was probably after your time.
Yeah.
He was left-handed, and we used to give him scissors on the left hand.
Left. And another surgeon who was left-handed who was doing transperineal prostates? Robotic transperineal.
Was that Chris Ogden?
Chris Ogden, yes.
Yeah.
He was a left-handed one. I saw him take scissors in his left hand.
Yeah, probably.
Yeah, Chris Ogden.
No, you can do on the left as well, but I think he wanted to demonstrate sort of going.
I wanted to show the top-down approach. So that's because that's the more common approach. And just to be safe that I was in the right plane, I did a small circumferential thing, so as I was doubly sure I'm in the right plane. I was neither in the prostate nor the bladder. Now once that's done, I'll leave this and I'll try to lift the prostate up. in the morning we had a good median lobe which Ashwin was holding. And once that's lifted up, make sure this opening is broad. A lot of times the mistake that we do is we make a very small opening here and the sides are still attached. So make sure it's all opened up. Like for example, it's not opened up here. So I'll try to open this up. And this is also a very fine balance because all the pedicles will start coming in. So you need to know where to stop.
As long as you're in fat, you can keep going, and then the moment it stops bleeding, you stop. You stop. It starts bleeding, you stop.
And then lift up the SV and the VAS, which we've already done. We'll take out the gauze piece.
See, this is the sort of teamwork you need, sort of unspoken. You know, the instrument was in even before Tushar said take the gauze piece out. It's very nice to see.
Hold this, please.
You are doing surgery with 30 down?
Yeah, now 30 down. I'll switch to a 0. Yeah, that's a good point. So I can continue with 30 now. You generally take 30 just for the bladder neck, but it's better and safer, I feel, to switch to 0 because with 30 you just see down. You don't see up, and we have to go up. So I would switch to a 0. 0 warm kar layer. Because the next step is now doing the pedicles. So this is again the denonvillier getting stuck onto the SV. Generally by sweeping movement this whole denonvillier goes down, but this denonvillier is stuck probably because of the T3 disease at the base, so I'll have to cut through the denonvillier. So एक बार change कर लो, फिर इसको पकड़ लो, then let's do the pedicles. Any questions till now? Any questions? Any remarks on the posterior dissection, Ashwin and everyone in the hall?
So one question on denonvillous fascia. Do you prefer it opening in the start while doing the posterior dissection or at this step?
No, so opening. Whenever I'm going behind the prostate, so I open the denonvillier, and my preferred plane posteriorly is an interfacial dissection, wherein I go between the two layers of the denonvilliers.
Do you think that interfacial dissection would be easier doing it right at the beginning or now when you pull up the seminal vesicles?
So I always do an anterior approach. So I do it now. The whole thing I do it now. But whenever if we are doing the posterior first, if it's easy to go ahead till the apex, go ahead. Sometimes the bladder is very floppy. It's difficult to go beneath the prostate. I leave after the dissection of the SV and the VAS and do that dissection that you're saying right now when I've lifted up the SV and the VAS. Because right now the bladder is not on top of me. I am on top of the bladder and it's not falling on top of my camera. Camera clean नहीं है, warm नहीं है, क्या नहीं है, ये warm हो जाएगा.
There's a smudge right in the center.
एक बार clean करना please. Thank you. So the main tips and tricks for posterior dissection is 1 centimeter above where you feel the rectum and sigmoid is going. Open the peritoneum horizontally and try to find the VAS. Once you've found the VAS, just be on the surface of the VAS, skeletonize it, walk along it, skeletonize it, divide it, and then go on to the SV and stay on to the SV. And all of this would be working in a horizontal plane. Thank you. So एक बार इसको पकड़ना, देखते हैं और कितना आगे तक हम लोग को जाना है या apex. I think we have reached the apex already.
Yeah, I think you reached the apex in the posterior section.
So see, this is stuck to the denonvilliers, so this is tearing apart. Generally, it comes out very easily. And he has Gleason 4 at the base. So what's important is to drop the bladder completely. So some bladder is still attached laterally. So this is what needs to go down. And once this goes down, everything will be pediclized in front of you. Okay. So this denonvillier, which is stuck to the prostate, should go down. You see this white shining thing? This is denonvilliers.
And if you are using hemolocks and clips,
Yeah.
what you will find is, unless you open the Denonvilliers medially and the endopelvic fascia laterally, the clips don't go on.
Yeah.
So you have to incise the fascia medial and lateral for the clips to hold.
So these are the two hard structures, as I mentioned, Denonvilliers on the medial side, endopelvic fascia on the lateral side, which does not allow the clip to go. And that's the reason you would have seen a lot of people making holes so that clips go on. If you open these structures on the two sides, you don't need to make any holes. And I don't make holes because I divide these two structures on both the sides. So this is the trick of the hemolocks going in without needing to make any holes.
So when you encounter like thick pedicle like this, have
very
you
thick.
ever taken the energy source
No, I've
instead
never.
of clips?
No. I can. You can use a ligashore here. एक इस पे लगा दो हेमोलॉक यहाँ पे. So there are paravesical veins coming in here. नीचे लगा दो ये जो lateral वाले पे. हाँ बस फैट पे लगाओ बस. Very hard. The Denonvilliers is very hard. It's not cutting even with cautery.
So when the pedicle is like this big hard, it always bleeds less, I
लगाओ.
think.
Let's see if it can go. हाँ. थोड़ा ऊपर. हाँ. Yes. So my prostate is here, and I'm this down, still it's this hard.
Yeah, it is miles away, the prostate surface. It is, I think, but what you showed us the picture, there is no extra prostate extension, but it seems to be have some extra prostate extension. Post biopsy changes some inflammatory response as well.
Hemolock. So my lateral fascia I've swept away. Medially I've opened the Denonvilliers. I've not made any holes. Let's see if this clip goes or not. Yeah, see, it goes and sits completely.
Dr. Tushar, this looks like the kind of prostate that we do. It looks like an LAPC.
Yes. So all the other 4 cases were Gleason 4+4. Only the case that Ashwin did in the morning was a Gleason 3+4. Hemolock, please.
Tushar, maybe on the next side, here you're clipping it wide, but on the next side, for the benefit of everyone who's here, maybe you can just show where the clips would go if you were doing a nerve spare.
So nerve spare, so all of this would come down. So you see this tissue, so this would all come down. And I would have probably gone here, clipped here and left all this tissue down. And I would have, just a minute, I would have swept more, separated all of it from the prostate as Ashwin was doing, the lateral hood. So this is mostly back bleeding because I cut cold. I used to cut with cautery, but in one patient I went into the prostate. So I realized if I cut cold, I'll cut only into the neurovascular bundle. I won't be able to cut the prostate. But with cautery, can go inside the prostate also. So since that day, I started cutting cold. So that's the reason for the back bleeding. Next, please. Yeah. So when you're reaching the apex, the hemlocks become a little bigger, and I switch to a metal clip.
Are these the Teleflex?
Teleflex,
mattresses?
yes. They are really good clips. ये Teleflex ही है ना, Praveen? So this is the venous sinus between the two layers of the fascia. The external fascia, the internal fascia, that's the prostatic fascia, lateral pelvic fascia, and all the muscles and the neurovascular bundle is within this fascia. Yeah, go for it. You have to move your scissor out of the way, only then your assistant will be able to come in. Very well.
Have you seen any clip migration into the bladder?
No, I haven't. Probably as the number of cases increase.
So we have seen, once our patient passed the clip also. That was in new bladder, not in prostate, but yeah.
Metal, another metal, sort of back bleeding. Yeah?
Yeah, we have seen quite a few patients with clip migration, and I think there's probably an element of anastomotic dehiscence or a reason for which these clips get incorporated into the whole healing process for whatever reason. And that's why majority of us have sort of moved to a complete sort of clipless operation, unless it's a very wide excision and very big vessels, then we'll probably use that.
So that's done on that side.
Stones have been formed over this.
I generally begin with the pedicles on the right because it's easier to get the prostate out, but the denonvillers was stuck there, so I started there. But generally, as a rule, start from the right because it's easier for your assistant also to come here. Once this is done, he has better access to the left side. This side looks a little better. So hemlock, please. A lot of veins in here. Here, paravesicle veins.
You can use ligashore as well.
Can use, sir. I've never used, but I think it would work equally good.
Because you are doing a non-nerve sparing.
Yeah,
so
yeah. So I could have gone with a ligashore.
And it will burn the residual tissue at the base also.
Yeah.
Sir, ligashore is your pedicle is so thick that you will not be able to, you will still have to, thin down the pedicle if you want to use ligashore. There is, using just a 5 mm ligashore will make you struggle as much as the clips. If you use the robotic vessel sealer, but then it's expensive, that will clip through everything.
So again, this is denonvilliers here. I need to take this denonvillier down, only then will the clips come on. Yeah. Yeah. So now the denonvilliers is down. I think the clips should come up now. इसको release. So release all the clips जितना लगा है, so इसको भी release कर दिया हमने. लगाओ. Yeah. Yeah. नहीं, thick. Oh, nice. खुल जाएगा. So Praveen says it will open up because he knows the feel of a closed clip. Because it's all, the fat is...
It's very desmoplastic
very
fat,
desmoplastic,
isn't it?
Yeah.
Was this guy ever on hormones or?
No, he's not received any hormones. So in fact, he was advised pre-neoadjuvant apalutamide.
Yeah.
Because of his, not by me, by someone else. I've not started using apalutamide, but because of
Proteus
trial, a lot of meetings around the Proteus trial, a lot of surgeons have started using it, but he did not. He did not take. It was just a.
Even before the Proteus trial came out, there are a lot of people who give neoadjuvant hormone therapy?
Hormone, yes, I also generally would give, if this patient was okay, but if I feel the rectum is doubtful, I would give, if he's insistent on surgery. Then I also have a lot of patients who I operate 3 months after starting hormone therapy.
Some patient even wants to wait for the surgery due to certain, some patient even wants to wait for the radical prostatectomy for some reason.
Yeah,
So
yeah.
they generally ask for this hormonal
Yeah,
treatment and they continue with this.
Ashwin,
So
have
it's
you
important to
adopted
get
this
all the fat
policy
down.
of downstaging locally advanced prostates, and then there has been no policy change after the Proteus trial came out in the UK?
Not quite yet, because the standard of care for sort of where the Proteus showed the maximum amount of benefit was for the locally advanced or possible N1 disease, which is something that, you know, increasingly we would offer it for T3A, T3B excisable, but the patients we actually operated on at the Proteus trial were majority of them you would normally not operate on, but because we could put them into the trial and put them on hormones, we were doing it. So they weren't our standard surgical patients. And the standard of care has changed massively with, you know, abiraterone, enzalutamide, and radiotherapy, high-dose brachy, all of that. So I think for prostate cancer, the oncologists within the US and the UK are extremely pro-systemic therapy with localized therapy to the whole pelvis. And so they would want to do that, but then when it comes to surgery, we haven't really taken that up yet. But I mean, I think it should be. I completely agree with Proteus. I mean, we were one of the biggest recruiting centers for Proteus at UCLH. And we had a lot of patients we operated on. So hopefully it'll make its way into guidelines.
Sometimes you feel as if there are two opposing philosophies at play. Yeah. On one hand, you are turning towards tests like Decipher to start early intensification of systemic therapy, because you know that these tumors are going to recur. So why do a surgery? Just hit them with molecules and genetics. But then on the other hand, you are pushing for downstaging potentially higher stage tumors to make them operable. So there are two opposing philosophies at play here.
I'm nearing the apex where the rectum starts to turn up.
Question to Tushar and Ashwin, Rahul. If you've put someone on hormones, are you going to re-image them before you decide on whether you're going to do a radical prostatectomy? Are you going to do an MRI?
So Madhav, I'm talking only about what I do. I never change my decision after I put a patient on hormone therapy. If I put a patient on hormone therapy, I probably do a channel to RP later on if he needs it and send him for radiation. I was just talking about opposing philosophies at play here, where on one hand we are saying that these are the group of patients who need early intensification of systemic therapy. On the other hand, we are probably when we find them operable, we are changing over to surgery. So talking about myself, I have never changed my decision after I have started them on hormone therapy, and I see a lot of locally advanced prostates. So most of them go for radiotherapy. Ashwin, do you want to?
No, my question was, say you've decided to do, you've decided, okay, I'm going to see this guy and see if I can do a radical prostatectomy on him.
Yeah, so I would do an MRI after 3 months.
Would you repeat an MRI?
Yeah, I would repeat an MRI.
Was my question.
In fact, I've had a patient who waited for 9 months. He wanted surgery. 6 months again, the rectum was tethered. He said, I'll take another injection and wait. I don't want radiation therapy. So I did his surgery, and the 9th month showed that it was smaller. The rectum was on DRE better, so I operated him after three shots of leuprolide. And every 3 monthly, I would be getting an MRI to see if I could operate on him.
So I come from a center where Dr. Rajesh Shalawat has been a very early proponent of neoadjuvant hormone therapy. He was using it for quite some time, even before the protease came out. And since the protease, I think last month just we have deferred around 10 to 15 patients for the next 3 months that we would operate them in November, December. So yes, as a protocol, we use both apalutamide and maybe oral antagonists like relugolix, and then image them after 3 months, maybe with both MRI and PET, and then operate on them, and then continue it for the post-operative 6 months again.
So regarding locally advanced, we have, so we are analyzing our 200 patients of LAPC.
Go to the apex?
We gave 6 months of hormone therapy. Then we invariably do imaging. We, in all of our patients, we have imaged them. We have done MRI, if required, a PET scan, and then we operate. So we've seen some good results. I think our result will come soon. So BCR, we followed the patient for 5 years. And we have seen that the BCR has come down up to 55% in our patient in 5 years.
Perfect. Should we go on to the DVC? Should I cut the DVC? Okay. Okay, so I increase the pressure to 20. So can we increase the pressure to 20? I put my progress inside the prostate, pull it down so that the puber prostatics are at stretch, and I make sure the sides have already been done so that I can appreciate the contour of the prostate. And then I cut the puber prostatic and then the DVC cold. Again, I feel if I use the cautery, I can go inside the prostate. Cold scissor will not cut through the prostate, it will cut only through the DVC.
Tushar, do you ever do suture and cut?
Sorry?
Do you ever suture and cut? Or
Suture,
always
no.
cut
If
and suture?
so only few situations where I've sutured and cut is when I was in London. African patients, huge DVC, like an IVC. So obviously, if you cut, it bleeds like anything. You don't see anything. So I then suture and cut. But as so, there are 2 spotters on both sides, almost always there. So buzz them. Rest, I don't think it bleeds quite a lot. Let's see if it bleeds today.
And question to Ashwin, so some people use a lot of energy around this area in the DVC, monopolar energy. Do you think it has any impact on the continence?
Mic not working. Please give the mic to Ashwin.
Yeah, I think that's a very good question. So I only use monopolar energy in probably salvage patients when the scissors cannot cut, or when you come across these straggler arteries at the DVC that you have to control before you proceed. Veins, I tend not to use energy, and I don't use energy by default. What you would have seen in the first case is I use energy when I start dissection of the urethra, because that's where we have had some patients who bleed, and the periurethral vessels, even with the DVC stitch, you cannot control, and it only stops when you start doing the anastomosis. So that's quite a long time for it to continue to ooze and bleed. So that's the only reason why I would use it when I'm starting the urethral dissection, but not at the DVC dissection level.
So again, I would go from the side and see the contour of the prostate, how it's going along the urethra. And I think this movement helps a lot. This sweeps away the tissue. Similarly from the other side.
One thing to note here is the constant irrigation by the assistant. So when there is a lot of blood there, the planes might not be easily visible, and of course, if we suck, then the bleeding will be even more. So constant irrigation helps understanding the planes here.
So I'll not chase the urethra inside because I think we have apical disease. Can someone see the planning sheet that's shared and tell me if there's apical disease I've forgotten? On the right side, apex 3 plus 3.
Yeah.
Left.
Left apex में कुछ नहीं है.
No disease. Okay, perfect. Then I can close.
And you can see how Tushar has changed the intensity of cutting from big cuts at the DVC level to small, sort of delicate cuts at the apex, just to try and make sure that you're not leaving any of the apex behind. And there is no harm in taking as much time as you want at this stage. You know, just taking a little bit of time here goes a long way in the patient's outcome, whether it is a positive margin or whether it is, you know, continence recovery.
Has anyone ever experienced in a case of locally advanced or maybe post-hormonal therapy where you start doing your posterior dissection in the midline and you're unable to proceed? Is it possible that you can approach this do all the dissection from lateral to medial? So this morning Ashwin showed us medial to lateral. Ashwin, if you can comment on if you've ever had to go lateral to medial from outside.
Yeah, that's a very interesting question. There's been, I think, 2 patients where it was not after hormones. I think it was just pure prostatitis reaction, which can be quite horrible. And, you know, just the bladder neck and the posterior dissection were absolutely stuck. So we ended up doing it almost like a open prostatectomy. So we did the apex, we did the lateral dissection like you suggested, opened the endopelvic fascia, did the apex and worked backwards because that was where we felt that there was an sort of an okay plane. And then we were able to then do the bladder neck after that. So that's the beauty of this sort of operation of having multiple approaches is once you understand the anatomy, you can try and find any space that you can get even a little bit of leverage and just go on with the dissection.
Dr. Sridhar,
Suction,
I have a question in my mind.
Yes.
If the patient is having, say, 150 gram prostate,
Yeah.
it is malignant, and there are some metastases as well. Patient's general condition is fit.
Relax.
He is doing yoga exercises daily. He can walk 5-6 kilometers every day. So what will be your choice? To go for a TUR channeling or you can go ahead with the radical prostatectomy in those patients?
That's a very good question. I think it's about balancing out what the patient has in terms of symptoms. I think the issue with large prostates and radical prostatectomies in sort of locally advanced disease, depending on where the disease is you might not be able to give them a good continence recovery if you do a radical prostatectomy. So although, you know, it might be a good option, what I would tend, and I have done this a few times, in patients who are very fit, but not quite 150, but like, you know, 250, 300 cc prostates, or very abnormal prostates that are sort of encroaching around the rectum, you know, they have been started on things like abiraterone and enzalutamide for locally advanced disease, but still they haven't had any effect on the size of the prostate. So I've ended up doing a simple prostatectomy, a robotic simple prostatectomy, and then they've had radiotherapy afterwards.
If suppose the rectal mucosa is absolutely free on rectal examination and there is no local regional disease basically, it is confined to the prostate, but he's got a metastasis.
Yeah.
So, and this patient requires a...
So here it's important to leave the urethra behind and just take the DVC. So if I take the urethra in my sutures, I'm going to injure the sphincteric complex. So my sutures, there's a big vessel here.
My question is that can we tell those patients that, well, you can undergo radical prostatectomy?
Hopefully soon enough. I think this evening Rahul is going to speak about surgery for metastatic prostate cancer. Kinju is going to speak on that, sorry. And we are currently running a multi-center UK trial called the President Trial on the use of radical prostatectomy in oligometastatic prostate cancer. So hopefully we should be able to allow us to do that in the future. Currently, the evidence is not there for surgery in oligometastatic disease, even if the cancer is localized to the prostate. But I mean, to be honest, these patients are very, very difficult to manage if they've got horrible symptoms. So they're going to need something doing for their symptoms.
Pressure down to 8, please.
That need not be radical prostatectomy.
Pressure 8.
But obviously that discussion is with the patient.
I think, Sridhar, at our time, it was due to the technical difficulties of doing a very good radical prostatectomy. That time, this procedure was deferred in these types of patients. But since we are doing a salvage nephrectomies and other things, and salvage cystectomies, so why not this procedure can be carried out in a fitter patients who are having obstructive urinary symptoms, who are likely to have more recurrent tumor development even after tumor channeling.
I mean, they're all very logistical sort of assumptions, and hopefully we can develop the evidence for it at some point. We just don't have the evidence there because the oncologists have beaten us to the evidence. So all the evidence in locally advanced and metastatic disease is driven by oncologists, and none of them, I mean, even during Stampede or any of these sort of trials, opening a surgical arm was a mammoth task because they would never allow us to offer surgery by itself. They wanted us to offer surgery plus standard of care, and because the early reports of Stampede had already established radiotherapy, they would not allow us to operate without them getting radiotherapy as well. So unfortunately, we are a little bit behind the oncologists in terms of management for metastatic and locally advanced disease in that respect. But hopefully, we will be able to get a little bit of evidence for it.
Pressure down
to 8. So that was a beautiful apical dissection and DVC dissection and DVC closure, Tushar. You can see the cuff of the periurethral tissue completely closed up and the urethra very stable, not disappearing into the perineum. So hopefully this guy, even though he's got high risk disease, will do very well.
Would you label this like a sort of a mini hood procedure?
No, this is not a hood. There's no nerve sparing for this.
No.
Yeah, I mean, to be honest, you've sort of spared the anterior supports, which is which has been very good.
Yes.
So,
so
because I keep making fun of Ash Tiwari that the only reason he named the hood procedure as a dash is so that he could have Ash in the name, and that is true. I mean, he says that the only reason he called it the Detrusor apron sparing hood technique. Why do you need to do that? It's because Ash is in the name.
In a more and more number of cases will be done with this type of a technique. Even in advanced disease, we'll get to know whether there is a definite substantial benefit for the continence.
Absolutely.
So I'll just do a rectal exam at this step once the prostate is out. And the next step would then be a lymph node dissection. So I'm just thinking, Ashwin, you've not shown it. Would you want to demonstrate the lymph node dissection? Because
I can do it, or if you want, I can do one side, you can do one side.
Yeah, probably, yes. Everyone could get to see your lymph node dissection. We didn't do that in the morning. And that's another thing which he does beautifully, going behind the vessels, lateral to the vessels. Yeah, so feels fine to me. No gloves, blue gloves visible. And no blood on my gloves, so that's fine. Hemostasis ठीक है? So I will change the mic. So Ashwin, एक बार camera clean कर दीजिए. You want a 30 or a 0, Ashwin?
Dr. Tushar, is there a reason why we are doing lymph node dissection before anastomosis?
That's a practice that I follow. I remove the prostate. So the main part of the surgery is done. Then I do the lymph node dissection. Because if I do the anastomosis and if there's some bladder handling, I have to move the bladder from side to side, my anastomosis may give way. So anastomosis is one of the most delicate parts of the surgery. So I would want to do it once everything is done. A lot of people do the lymph node dissection earlier than even the prostatectomy. I like to do it after prostatectomy because I find prostatectomy the more challenging part. Lymph node is the easier part. So prostate out, then lymph node, and finally the most delicate part of the surgery, that's the anastomosis. Mic nahi chal raha hai. So Kinju, could you hear me?
Hi, we can hear you.
Okay, you can hear me. Perfect. So the reason I do the lymph node before the anastomosis is because I feel the anastomosis is the most delicate part of the surgery. So I would do all of the extraoperative surgery and then finally do the anastomosis. So that there is
no push and pull in the bladder.
No push and pull on the bladder, because for lymph node, I would be pulling the bladder to the opposite side.
Yeah.
So with the template for the lymph node dissection, what I usually do is I go up to the ureter, so slightly different from the lymph nodes that we do for bladders. So we'll start off with completing this sort of incision to get the vas. Right, can I have a clip on this, please? So the lymph node dissection is probably the only place where I would put clips, because there is evidence that it reduces the risk of lymphoceles, because no sort of diathermy really helps with reducing lymphoceles. So the first step is trying to get the vas out of the way, which we have done here. So the next is to get incise the peritoneum along the external iliac artery. So we don't want to go too lateral to the artery, because that's when you start to get lymphatic edema. Now what can happen quite easily at this step is the lymph node packet can come onto the bladder. So what we want to do is we want to make sure there's space between the lymph node packet and the bladder. So there you have the artery, the ureter going here. So these are your landmarks. Medial umbilical ligament. Just medial to the medial umbilical ligament is the ureter. And what you don't want to do is you don't want to go medial to the medial umbilical ligament. That's when you hit ureteric injury during lymph node dissections. So again, my Maryland is protecting the ureter, pulling it away, and making sure we get to the bifurcation of, sorry, if you could just come back for a sec, yeah. So this is your ureter here. So this will be the bifurcation of the, yeah, this is ureter here, and this is your bifurcation of the external and internal ilia going down. So that should be fine in terms of a medial limit.
So Dr. Ashwin, does your lymph node, the area of dissection changes as per your Gleason score? How do you decide the template?
No, not as per Gleason score, as per the pathology. So if this is bladder cancer, what I tend to do is I tend to do a lymph node dissection which is pre-sacral as well. So I would start from the bifurcation of the aorta. So I would start from here for bladder cancer. But for prostates, I don't go that medial. I don't go medial to the ureter.
So in your practice, you are doing lymph node dissection from intermediate stage onwards, intermediate risk onwards?
No. So the patients we do lymph node dissection on, which is probably slightly different from practice from what happens in India, is we do not do lymph node dissection on everybody.
Yeah.
I would do a lymph node dissection only on patients with a primary pattern 4, and along with that, they need to have a PSA above 10 and plus or minus T3 or locally advanced disease. So if they've got T2 disease, primary pattern 4, I wouldn't do a lymph node dissection. But this is obviously Gleason 8, probably T3, so I would do it. So you can see the nerve quite well here, which is the genitofemoral nerve. We can go a little bit lateral here. This wants to come with us. Might just change the energy controls back to 4.
So during the lymph node dissection in the post-op period, have you ever encountered any patients having persistent lymphoria, high output? Like we have encountered 1 or 2 patients for those who have to do like lymphatic embolization. Have you encountered any of those?
I have unfortunately seen that, and we have done exactly the same thing. So we've got some very good interventional radiology colleagues who we were called in to do the lymphoscintigraphy and embolization with foam and gel and glue and all that. And it works very well. It sort of goes away completely.
So in that case, you like to do some clippings of the lymphatics here if it is visible. Like we very often saw a large lymphatic tram at the root of the external iliac. So do you like clip those lymphatics routinely?
Yes, so I don't clip them here yet. I will clip them on this side. This is usually where they leak from. This side I'm not, so the leg lymphatics are usually lateral to this, not where I'm taking them. And again, the superior or lateral target is the bone. So I'm going to go across.
Ashwin, do you have any experience with the drop-in probes that have come up for intraop assessment of the nodes?
Yeah, so we did that. We did that as a trial very long ago. Something called Neptune. All these really fancy names for trials, I must say. But it was called Neptune, and what we did was we had we had a drop-in probe, and we also had a gamma probe. So both of them, and we were testing feasibility to see that with PSMA tracer. So there was a PSMA tracer, it was a hybrid tracer. So it was a PSMA tracer which had fluorescence and it had gamma activity. So, we didn't do it for too many patients because, it was like if I did one case, I couldn't do another case for like probably a week to 10 days because of the amount of radiation exposure that created. So we ended up doing, I think in total probably 10 cases and did a proof of concept. And I think that company now has called Lucida. I think they've changed their brand name to Lucida and they've developed some probes to use. So usually you get the circumflex vein on top, and that is usually the limit of the lateral dissection. Sometimes it comes down. It has a sort of a branch that comes down, and you end up taking the lymph node packet around it. But here it seems to be okay. So that's staying up there. That's good. So this is pretty much the lateral dissection pretty much done. Now I do a little bit of a split and roll sort of dissection on the edge of the external iliac vessels, and you'll see what that means. Let's got some notes here. So again, these are lymphatics. We'll see if we can spare it. So these are the lymphatics of the leg. So this is the sort of split and roll. So this is my lateral edge of the split here. And I will go lateral to the vessels in a little bit.
So, which are the important places where you're placing a clip?
Where I'm putting a clip on, if I see some big vessels, and mainly when I go, actually this is a place where I do put a clip proximally. So let's put a clip on this.
Yeah, this is the place I was talking about. Usually you encounter a large lymphatic trunk here.
Yes, proximal and distal. I mean, here it was not that bad, but you'll get them here.
Yeah, yeah.
Yeah. Okay, yeah, thank you. So that'll be my proximal extent. Say that again. So I sort of release it. So I do this release, then I do this lateral release, which I'm doing now. Then I'll do this release, and then I'll go posterior and pull that packet out from there. So it's not quite a top to bottom, bottom to top sort of approach. It's about rolling it around the vessels and then finally taking it out. So that's the ureter again. So finally taking it out from here. Let's have a look here. That's fine. So this is the other place where I would put a clip.
So far this has been en bloc dissection.
Yeah, the whole lymph node dissection is en bloc. I don't take it out in packets. Yeah,
so what is your distal limit of the dissection? Like this aberrant obturator vein?
Yes.
This is your limit?
This is the circumflex iliac. This is not the...
Yeah, circumflex iliac.
Yeah, clip there, thank you. Yeah, so that is my lateral limit. Sometimes it sort of goes down. So if it goes down, then you have to split it around it and sort of take it. Here he's got a bit of a tributary of that vein going down. And you sort of have to go down till the obturator nerve, which will come here after the obturator. This is obturator artery and then obturator nerve. So the next step is doing the medial dissection. So holding the medial ligament to make sure the ureter is not coming into the dissection here. So the medial ligament automatically pushes, this is the ureter here. The medial ligament automatically pushes the ureter away. So this now will be my proximal extent, which we have already clipped.
So do you ever go
suction
lateral
here.
to these vessels, extrailiac vessels?
Say again?
During the lymph node dissection, do you ever go lateral to the vessels?
I will go lateral. Okay. I'm just releasing this. So I did the lateral, so I did the sort of this lateral or superior extent. Now this is the medial extent, and I won't take it out from here because this is where the whole lymph node packet will come out. But what I want to do is just release this bit, because if I release the lateral bit without doing this, then it'll become too much of a packet to lift up and separate out.
But what I have seen in my practice, if I do lateral fast, then I have already identified the obturator nerve. And these tissues which are stuck on the veins, they are already gone. So it is little bit easier for me in this step.
So I have already seen the nerve, but I don't want to do too much more there because I want to go here. So here what we are trying to do is go between, he's got a bit of an ectatic artery. So this is the plane we want to be in. Not here, but sort of medial to these lymphatics if possible. And along the psoas muscle. So this is more to control the perforators that are there. Might have to take this. So one is a lateral dissection between the muscle and the lymph node packet, and that's where you control the perforators.
So I also like to go from here only, Ashwin. That the reason is that I bipolar preemptively all these small perforators.
Yes.
So because this is what bleeds during the lymph node dissection. Small vessels coming from the muscle and going this. So you can see there, just beneath the scissor, there are small vessels.
Yeah.
So I go and bipolar them preemptively, and after that, it's all a bloodless field. You sweep, nothing bleeds. Yeah, the one he is bleeding, one he is bipolaring. So that's the one, the small. If you come from the medial side, you're not able to see because these are all behind the lymphatic packet.
So now I'll go proximal. So you can already see the vein coming there. Yeah. Now, I wouldn't be surprised if he had positive nose, but hopefully he doesn't.
It was negative, I think.
Yeah, so hopefully that'll be negative. So my proximal limit for this is the perforation of the obturator vein. So we'll see where that comes. So there, I think that's where it is. And you can see the obturator nerve here. So I won't go too deep at this point. So I'm going closer to the nerve than the vein, because the vein can obviously bleed. And then the next step is going between this packet and the vein, which is probably the trickiest bit of the dissection. Let's start from a bit higher up. So there's the edge of the vein. Seems to be some nodes between artery and vein. quite stuck onto the vein. So at this proximal bit, what I tend to do is lift this whole packet up and then almost lift up like this, thin it out to see the nerve, where you can see there. So once this is sort of taken off the pelvic side wall, we should be able to go to the other side. So I think that's all taken off now. This is vein, this is nerve. So once we take it off the nerve, then we are pretty much done.
After a good node dissection, what you're doing here, what is the incidence of your patients having penile edema, lower limb edema, and do you find it challenging that they've gone through this major surgery, but that is the thing that bothers them the most?
Absolutely. And one of the things that, penile edema not as much. Lymphedema also not as much, because I haven't gone too lateral with the dissection in terms of taking the lymphatics laterally. But even worse than that is DVT. So if they get a lymphocele along the veins here, then the risk of DVT is quite high. So that's one of the worst complications you can have after a lymph node dissection. Everything else you can sort of sort and tolerate, but that is something the patients will absolutely hate. Because sometimes the DVTs that you get from this sort of dissection causes what's called a post-thromboprophylactic inflammation. So, and then that really is a long-term condition that cannot be helped, really.
Dr. Ashwin,
Yeah.
in the lymph node dissection, especially in the prostates,
Yeah.
we generally avoid going lateral to arteries. What is your opinion on that?
You avoid going lateral to artery?
Too lateral to arteries, yes.
Yeah, so lateral to artery would mean this, right? So these are your lymphatics of the leg. So we're not going lateral there, but what I've done is I've gone lateral just to clear the fossa of Marseille. I haven't taken any tissue from here. So, although it is quite skeletonized in him, there's nothing much to take, to be honest.
I think the lateral extent of an extended pelvic node dissection in prostate is up to the genitofemoral nerve.
Yes,
so you have to go lateral to the artery.
Which is here. That's your genital branch of genitofemoral nerve.
And if you're doing a lymph node dissection in a high-risk prostate cancer, you have to do
We have to do an extended, yes. If you are doing, you should do extended.
Actually, the evidence from the randomized control trial is there is no difference between a standard and an extended. There was a German randomized control trial said that, but to be honest, the Germans, when they do a standard, they do an extended. So what a lot of places would call as extended, they would call as standard. So I think that's probably a bit of a red herring with that sort of study, but this, that's an involved node. So this is, I don't know, not looking good for him. Hopefully it comes out negative.
Ashwin, do you have something against the Germans?
I have absolutely nothing against the Germans. I love them.
This is the third time since morning that you have held them accountable for. Do you drive a BMW, Mercedes, or you are strictly into Korean cars?
I actually drive an Audi.
Yeah, so you're driving a German car.
No, I don't have anything against them. No, what I'm saying is they're so good and so thorough, even in their standard dissection, that they would probably call this a standard dissection. They wouldn't call this an extended dissection. So that's why they probably showed no difference between a standard dissection and an extended lymph node dissection. So they did a lot of video analysis when they did their study. And if you look at the templates that they described for standard, you know, a lot of the world would describe that as extended. So I don't have anything against them. I think they're amazing surgeons. But the problem is their trial, unfortunately, reported as such for this particular reason, I think. In fact, they had a similar trial for bladder cancer, which reported very similarly. Yes.
So probably they did the similar thing in
Yeah.
bladders, where they said that there's no difference between extended and...
I mean, I have seen German surgeons do lymph node dissections, and you know they will do pre-sacral lymph node dissection as extended for prostate cancer, which you don't need to do pre-sacral lymph nodes. So this is on block. Yeah, I do. Well, actually, my wife drives it.
e-tron.
Yeah, I walk. I travel by train. I don't have the luxury of going in a car. Right, so you can just sort of have a look at the anatomy. So I will probably take this back because you're going to have to do the... Is this going to open up? It might open up. Thank you. Yeah. Thank you. Right, so looking at the anatomy, lateral limit. So if you go too lateral here, you go into the lymph node of Cloquet. That can also cause a lot of lymphatic issues. If you go more lateral than this, then that will also cause a problem. That's your genitofemoral nerve. You've got your circumflex vein, that is here. You've got your obturator nerve and vessels underneath. And posteriorly, you have the obturator vein that goes here outside the sciatic foramen, and the obturator nerve here. So that's your limit of, in my view, an extended lymph node dissection.
Dr. Ashwin?
Yeah.
Yeah, sometimes we see on PET scan that there are small perirectal nodes and presacral, and then we start neoadjuvant on that patient.
Yes.
And when we operate upon such a patient, what will be your, template for lymph node dissection?
So that will be very similar to a bladder. So that will be from the bifurcation of the aorta. So you sort of start just at the level of the IMA, and then you go into the presacral space all the way distally. And that's where I would take them as two parts. So you've got the ureter in the middle. So I would use the ureter as a dividing line. And so I've gone lateral to the ureter. And then if I wanted to go sort of presacral, I would go here, go medial to the ureter, and go under bifurcation of aorta, reaching up to the left side and take all of that out. But I mean, that's not standard for prostate cancer.
Done?
Yeah.
Perfect. Thank you. So thank you, Ashwin, and I'll take over and do the left side, and then we'll do the anastomosis after that. So I think everyone could appreciate how he was moving the bladder from side to side. He was pulling the bladder to the left. So that's the reason why I would not want to do the anastomosis before the lymph node. But even if you do it, I don't think it would be disrupting it.
Have you tried not dividing the vas and using that as a handle during your node dissection?
So I divide it. I have left it in a couple of cases when I was operating with surgeons who would want to leave it. but I feel you need one hand to just lift it up, either your assistant or your fourth arm. So it's better because it's already divided medially, so there's no point in preserving it here. That's what I feel.
Just for traction.
Sorry, just for?
Just for traction.
Traction. So I always divide it. So I'll divide it on the left side also. So yeah, let's go. Let's see the anastomosis once. So amazing. So that's a lymph node dissection that we generally would do for a bladder cancer. So एक gauze piece रख देते हैं. These are the posterior urethral vessels that are bleeding here, which will stop in the rocos. So एक gauze piece रख दो. And this is a 30s. Dena? Yeah. So, if you remember, I had cut the urethra cold. So there are vessels on the urethra, which Ashwin also was talking about. So these continue to ooze. So if you're doing a lymph node, it's just pack it up with a gauze piece, because as it is with the sutures, most of them will stop. And the rocos.
Tushar, do you remember Dr. Murugesan Manoharan speaking about those vessels?
Yes,
So
absolutely.
Since that time, I've started taking a small stitch even for prostates in that area.
Yes. So I take that during the Rocco stitch. So Rocco's takes care of that.
I also take it invariably most of the time, because that is an annoying bleeding that happens, and separately I tend to...
Perfect. So this is all good. So these are the perforators I was talking about. These are the ones which bleed. There's nothing else in this area to bleed. And if we don't go from here, if we're going from here, we pull the nodes. The nodes come and these perforators get avulsed. And because there are nodes here, we don't see what's bleeding behind. So if you go from the lateral, you are going behind the nodes and hitting the perforators, bipolaring them, and then nothing bleeds. एक बार start कर देना please बेटा. ठीक है, looks okay. The hemostasis looks okay. ठीक है. So now we'll go on to the left side. Left side, I had not dropped the bladder completely, so all of this should have been dropped during the bladder drop, but because it was a very small prostate, I skipped that. But now I'll have to do it because we have to do the lymph node. The obturator nerve will always come below the bone. So till the time you are on top of the bone, you're not scared of the obturator. The only thing that will come here now is the vas and then the vessels. यहाँ पे start करना क्या है? So this is the vein. So let's open this a little. Obturator nerve. This is all paravesical tissue, paravesical vein, fat of the bladder. This is... You see these veins here, these are a part of the bladder. So lateral vesicle veins.
So do you routinely identify the umbilical ligament as the...
Yes. So my target is to go to the umbilical ligament because that's my medial boundary of lymph node dissection. Hemolog, please. So that's the vas. Yeah, आ गया. Medial umbilical ligament. So that's my medial boundary. I'll stop here. Everything medial to this belongs to the bladder. So during lunch we were seeing the pedicles of the bladder. And the ureter just medial to this. Ureter again will be medial. So lateral, you're not scared of injuring the ureter. The ureter will always be medial to this median umbilical ligament, which is here. Hemolog, please. vein. लगा दो, आ जाओ. Yep, thank you.
This is what many surgeons would use as the handle to pull. The assistant would catch the vase.
Yes, so now I will leave that. He knows the next step, that's why he's come in. So he'll hold this, I will hold this, and we'll open it up. And his sucker will take the sigmoid colon away. So now everything is open. I think the ureter should be here somewhere. So the next step is to open the peritoneum along the vessels. Again, single blade. Till I see the ureter. That serves two purposes. One, I've reached my proximal limit till the ureter, and when I see the ureter, I'm sure that the ureter is safe and that I would not injure it. So it serves both the purpose. That's the reason I go down till the ureter. We have not got the ureter till now. कहाँ है भाई ureter? This? Should be here. Yeah, I just wanted to see the ureter once. Yeah, I'm too proximal. हाँ एकदम दो ओटी कल चला लेंगे. हाँ या दोनों ओटी में ओटी 2 में भी एक केस लगा लेंगे ओटी इसमें लगा लेंगे. हाँ दोनों साथ में 2 ओटी स्टार्ट कर लेंगे सुबह. हाँ ठीक है. So I still haven't seen the ureter. एक मिनट. So I'll just open it up a little more. This should be the one. Let's see. So that's my oblated umbilical artery. If I cannot find the ureter, I'll just go medial to it, but I think this is the ureter. Let's see. That's my medial boundary. Yeah. So let's see. Yeah, this was the ureter. Let's see if there's a peristalsis. Yeah, should be the ureter.
You can see peristalsis in proximal. Yes. Just inside.
Yeah, I'll just open this peritoneum. So that will be my proximal boundary. Yeah. So now here I generally ask my assistant to come and get his sucker here. So he'll protect the ureter also and he'll retract the ureter also. So ureter going medial to the medial umbilical ligament. Ureter medial, lateral is the medial umbilical ligament, and this is our proximal boundary. Nothing medial to this. So we stay lateral to this, and everything lateral to this comes out with the lymph node. This is probably the superior vesicle coming out of the oblated umbilical artery. Oopsie. His fat is as if he's taken hormone therapy for about 6 months. Very desmoplastic. Okay, now that we have defined our boundaries, now I go from proximal to distal. I know my ureter is here, so my assistant will be here. That's the crossing of the iliac. So I'll pick up the tissue on the artery. So again, that's not good. So I touch the artery. And go just on the surface of the artery and lift everything up. Praveen, उस पे एक सूचर ले लेंगे. So just on the surface of the artery is an avascular plane. And I generally don't go lateral to the artery.
Yeah.
The vein is coming over the artery.
Yeah, on the left side, you very rarely need to go lateral to the vessels because your right-handed scissors allow you to dissect a lot better and pull the tissue out. It's more on the right side that you need to go behind the vessels.
There's a blob of fat, probably the cloacoid node, but it's almost always negative. Inferior epigastric.
I have a question for Ashwin, Tushar, or anybody who's tried it. When you're doing these big, large lymph node dissections, have you ever tried giving them some ICG just to check if any site is leaking? I'm not talking ICG
Looks
for
like
picking up nodes. I'm saying you've clipped just to see if there's any leak happening somewhere.
I think that's a good idea, but I think we haven't done it. The problem is, by the time it gets to the lymphatics, and you do the lymphadenectomy, the ICG is in circulation, and I think it's starting to get out of the system. So we have never used it to identify leaks. The gynecologists use it for picking up lymph nodes because they're very big on dynamic sentinel lymph node dissection, etc., for cervical cancer. But obviously, it's not something that we have evidence for in urology.
would you say this where Tushar is cutting now is the place where most leaks happen?
Yeah, could be. I mean, it's sort of just above the bone. I think that's probably going into territory of lymph node of Cloquet's. So
And I often find the assistant finds it the hardest to put the clip there.
yeah,
So the right side, this clip goes in on very easily. And invariably, at least in my practice, this side I'm not clipping and just using bipolar and hoping that it is going to seal up.
I mean, to be honest, a telltale sign that they're going to have a lymph leak is when you're doing this lymph node dissection and you detach it and you see weeping fluid after the lymph node dissection, and then you know that patient's a sitter for a lymphatic leak. But here, I think we're seeing it to be relatively clean, so I think it should be okay.
So these are the perforators that bleed.
So then do you use any particular nomograms to decide when to do lymph node?
Section karana, I guess.
No, I think I'm a bit biased when it comes to majority of academic research, to be honest, because I think there's a lot of bias in these sort of studies to try and identify why they want to do lymph nodes. So, you know, all these nomograms talk about potential lymph node 5% as a cutoff for doing lymph node dissection. But to be honest, you know, the complication rate with lymph node dissection is almost 35%. So what's your trade-off for 5% picking up? And the second thing is, you know, a PSA is an excellent marker for, you know, if they've got residual disease after a prostatectomy, for them to have salvage whole pelvic treatment. So in that scenario, taking these lymph nodes out, even if it could be involved 5 or 10%, to me makes no sense.
So in case you don't want to go from the sides, which in prostate I generally don't disturb this, so what I do is roll down all the vein here. In bladders I always go from the side what Ashwin showed there, that side. He only taught me this going the lateral thing. So in bladders I do that. In prostate I generally take it out from the medial side.
So you decide based on the PET scan, PSMA PET?
Unfortunately not, because PSMA PET positivity is for in clinical N1 disease, we don't offer prostatectomy. So we would still do lymph node dissection if they have Gleason 8 or primary pattern 4 with a PSA above 10 and locally advanced disease. But if they have T2 disease, then we're a little bit more lax. We'll probably say, you know, it needs to be really high PSA for us to do it. I mean, currently we're doing a trial called ELLIPSE. So we've stopped doing lymph node dissection completely unless the patients enroll into the ELLIPSE trial, where intermediate and high risk prostate cancer, we do extended lymphadenectomy for them. Otherwise, we tend not to do it. It's the only way we could get patients recruited onto the trial.
It's more of a clinical judgment than one particular factor. Right? Yeah.
And majority of my colleagues wouldn't do lymph node dissection. Probably urologists across the UK wouldn't do it. It's very, very rare.
Okay, so we just need to divide this here. The medial is defined. This is the ureter. One more area where obturator is likely to get injured is we've seen it that side, but we've not seen it here. So we might, if we keep going blindly here, we might injure the obturator. He is going to have a good lymphatic drainage.
So have you ever used the fourth arm to retract the vessels here at this stage?
Yes, we can use that.
then there's the risk of DVT in that as well.
There's a direct branch from the vein here. I'm just trying to
No,
avoid
not
this.
really. I think the risk is quite small, but I think it's about trying to see what you'll get the max out of your fourth arm. I personally, tend to either have it up lateral or down medial on the medial ligament, so I know exactly where the ureter is and the medial ligament is. But you could have it on the vessels if it's easier.
That's the nerve. Now I've seen the nerve. Now I can chop off everything. Another trick is to just slide on the nerve. If you slide, everything will come off. This patient, the fat is a little desmoplastic. That's the reason why it's not coming off, or else everything, when you slide on the nerve, everything comes off. Okay, we need to see where this is coming from. There's some bleeding there. Bag अंदर है? हैं? Bag अंदर है? Okay. Let's see the hemostasis once. यहाँ पे सर करना हो सकता है, ये रिथरा से ही आ रहा हूँ, वॉश कर ले एक बार। यूरिन भी है, यूरिन भी आ रहा है ये। Ashwin, are you happy with the lymph node dissection? We want me to remove these? I think this will be an overkill. Yeah. So just let's see that. So this is the clipped vas. This is the obliterated umbilical artery. And this is the ureter going medial to the obliterated umbilical artery. In a cystectomy, we would have gone here, pedicalized and taken this pedicle, got the ureter out. कहीं से आ रहा है? उसी है कहीं? नहीं तो फिर anastomosis start करेंगे. Sorry? There no bleeding? Okay. Okay. Suck here. Somewhere. Okay. Perfect. So let's take 2 needle drivers, please. Two needle drivers. But a 0 change कर देना. What is up? All well? Blood pressure and all, everything okay? Just anastomosis, last 15-20 minutes. So for all our participants in the evening, Ashwin, so we have a very special lecture from Ashwin on the functional aspects of robotic radical prostatectomy. So he'll deep dive into all these steps that we have just discussed today. And we have 3 panel discussions on different the stages of prostate cancer: localized, oligometastatic, and metastatic prostate cancer. It's at Essex Farms, which is just about 10-15 minutes away. And we have cabs downstairs for everyone to be taken there. So this would be, I think, a 25 centimeter 3-0 V-lock, Praveen? V-lock 3-0, 25 centimeter 17 millimeter needle. There is some oozing which is here. इस corner में दिखाना ज़रा कुछ है क्या? हाँ देखना कुछ तो है यहाँ पे. Yeah, देखा ये bleed कर रहा है. Wow. Suck. So this was what was pooling up. Needle helps you in holding up the tissues. बंद हो गया? नहीं हुआ तो Rocco's यहीं से start करते. So Rocco's stitch is a 3-point fixation. Start from the denon-villus, posterior detrusor fiber. The second is posterior detrusor fibers. Every time you pull, zoom out your camera like this and pull like as if drawing water from a well. So again, don't hold it like this. Hold it from the tip and don't hold it here. Hold it at 2/3 and 1/3 here. So this is the best way. It will give you the rotation. Now the posterior detrusor fibers, lift the bladder up, see where the mucosa is. This is the mucosa. Go lateral to it, posterior detrusor fibers, and rotate. Rotate, zoom out, pull. The third point is posterior detrusor posterior urethral fibers. Lift the catheter up, perineal pressure, and take this. This again will help in closing all the veins that we were talking about, the ventral venous plexus. I mean, a little lateral. Generally, don't go that lateral because of the venous sinuses there. Don't tighten it completely. If you tighten it completely, the bladder will come and sit right now. We don't want, because we want 2 more rows of sutures. Posterior detrusor fibers, denon-villus fibers, posterior detrusor fiber, not the mucosa, just the posterior detrusor fibers. This would be just left of the midline because we'll take one right on the midline and then one here. Posterior urethral fibers. Again, Denon-Villiers.
So you invariably use 2 needle holders while doing
Yes,
this?
always. I always, because I feel this is the most important step of the surgery, which is going to have a bearing on his life, quality of life. And also because it all depends on how you are trained. I was trained with 2 needle drivers, so it becomes very difficult for me. Mother was saying he took 2 needle drivers, but he couldn't do any, switched back to a bipolar. So it all depends on what you're trained with. I wish I was trained with 1 needle holder and 1 bipolar, but NHS has a lot of money. So every case NHS uses 2 needle drivers. So I was. Okay.
Yeah, I think Max has a lot more money than the NHS.
So we don't have the luxury to use 2 needle drivers. In fact, we only use 3 instruments: 1 fenestrated bipolar, 1 scissor, and 1 needle holder.
Wow. So this is Rocco's done complete.
Progress.
So I've not come through the mucosa. Rocco's is just till the posterior detrusor fibers. 4 throws here, 3 throws there, and we start tightening from the second one. So this would be away from the bladder, vertically up. So hold with the left arm, pull with the right. This comes and sits there. Once this is tight, keep holding there, and now start tightening the third one. Yeah. So now the third one is tightened. I'll hold the third one and I'll hold it there, and the fourth one I'll start pulling. So this Rocco's is completed. This makes my bladder come and sit at the urethra. Now with the same suture I'll continue with the anastomosis. The posterior plate and the left side I'll do with this suture. When you're starting on the right side till 3 o'clock, it would be right hand, and when I cross 3 o'clock, it will be left hand, opposite hand. Right now I'll be doing the posterior layer. So posterior layer 3 sutures: 5 o'clock, 6 o'clock, and 7 o'clock. The 5 o'clock and 6 o'clock will be right hand, and the 7 o'clock would be left hand. So 5 o'clock suture, the first anastomotic suture, full thickness, mucosa to mucosa anastomosis. And don't pull like this, rotate. Sorry. Thank you.
You're even though you're still at starting the posterior plate, what is everyone's opinion on not taking the urethra in the anterior aspect?
Catheter back, please.
Because the guys in Martini Clinic
please.
routinely don't do that. They will
Catheter
just
tip.
take the bladder and suture it to the DVC above.
So I'm not sure how the results would be for that.
I mean, to be honest,
If it's not a mucosa to mucosa anastomosis. Sorry, Ashwin. Yeah, please go on.
So there are a lot of ways of doing this. I mean, there was a study even from a Mexican urologist who put no sutures at all and just put a catheter in with 30 mils in the balloon and left it in for 3 weeks. And then he said there were no strictures. And I think I find that hard to believe. I think, if you don't have mucosal apposition, this is not the only place. I mean, if you look at urethroplasties, if you don't have mucosal apposition, then you're going to get strictures. It's as simple as that. So what the Martini Clinic are talking about, sort of suturing the bladder to the periurethral tissue, is sort of, I'm not quite sure what they want to achieve with that. It doesn't make it quicker. It doesn't make it less bleedy. It doesn't make I'm not quite sure what the advantage would be. But I guess with these sort of things, you can always report very good outcomes until everything horribly goes wrong. And sort of it's the basic steps that are the ones that allow you to get good outcomes consistently across easy and difficult cases.
So this was a 7 o'clock, so I switched to the left hand.
I agree to Dr. Ashwin here, because when we do a good mucosal to mucosal anastomosis, we don't see strictures later. So we don't know if we don't take mucosal to mucosal anastomosis, the rate of stricture, nobody knows.
So this is the posterior plate completed. Now we'll tighten the posterior plate. 3 rows of sutures, 5, 6, 7. Start with the 6 o'clock one. Again, as Rahul said, pull away from the bladder. So tighten this up. Now once that's tightened, go to the other one, third one, and pull this vertically up. And tighten the third one. It's always important on the urethra, if you're tightening, pull perpendicular to the urethra. Urethra is like this, pull here, not in this direction because it will cut through. So pull in this direction. Now when you've done the posterior plate, ask your assistant to put the catheter in and see if it's going completely inside or not. So I think that's a good posterior approximation. Ashwin, you okay with this?
Yeah, that's right.
Okay. So now what's remaining is left side and right side. I'll use the same suture for the left side, come till the 12 o'clock. You take a new suture and come till 12 o'clock. This suture is a left hand forehand. I'll keep talking about the hand so that this goes on record, and when you all see this video again, you know which hand to be used. So left hand forehand. This would be a left hand backhand on the urethra inside out. Catheter, please. Yeah. Back, please. And it's important just to take the urethra and not all this tissue, because it will strangulate all the blood supply. So, and again, pull in this direction perpendicular to the urethra and not like this. Left hand forehand. And now we are coming to the 9 o'clock and 3 o'clock. Ashwin talked about the tennis court. So we are coming to the net area of the tennis court. We are crossing that. So the hands crossed now. So this area now anteriorly would be done by right hand. Back, please. Again, don't pull, rotate. Because we have come anterior, cross the net, so now the hands cross. For the left side, it will be a right hand, backhand. Suck, please. Catheter, please. Right hand again. So probably one more and then we'll take the other suture. Again, right hand, backhand. Make sure that you get the mucosa. I think I've got the mucosa. Yeah. 1 minute. फिर से देखते हैं mucosa है कि नहीं. Yeah, so this is the mucosa, just at the edge of the mucosa. Catheter back, please. Next suture, please. Thank you. So this is the expertise of assistance you need.
You're getting what you need before you ask for it.
Because every step I do the same thing. So he knows we don't talk during the surgery. As I said, this is important to lock it here or else it will keep sliding. So take one more bite through here. This will keep it in place and the loop will stay outside. So that was right hand, forehand. Now right hand, backhand. Back please, catheter. Rotate, come out. Don't lock the suture. Perpendicular to the urethra. Right hand, backhand. Now probably we can switch to, we've crossed the net of the tennis court, so probably switch to left hand. Got the mucosa. Catheter back, please. Rotate, rotate, rotate. Yeah. Catheter डालेंगे एक बार अंदर जा रहा है आराम से. So I think 2 and 1 more here. Going in completely. ठीक है. चल पीछे ले लो. Left hand, backhand. This is again left hand. Catheter tip, please.
So surgeons in the other hall, any other variations of doing the anastomosis, maybe with catheter in place or 2 interlocking sutures? Dr. Kinju, Dr. Madhav, your comments?
So we use 2 different sutures. Our way of doing Roku is slightly different, where I take 1 suture, 3-0 V-lock for Roku stitch, followed by 2 different 4-0 V-lock suture for anastomosis, and the same Roku stitch that would be there, we would follow it anteriorly and we would come and do the double layer. Madhav, how you?
So I use a double needle Stratafix, so no knots. I most of the times don't even knot anteriorly because I use the same suture to do the anterior reconstruction. The Rocos, I was saying in the morning, I do a little differently. I do a 3-layer Roco, 2 layers posteriorly, and the third one is the posterior plate, the bladder neck and the urethra.
Back.
And then just use
Dr. Rahul, your comments?
knotless Stratafix.
So you take a suture, so you take a double-ended quill sutures.
And not a quill, the same Stratafix what he is using, but that is a 2-needle Stratafix. It is about 26 centimeters. So I use a
So if you take a double-ended suture, the first 2 bites will be in the midline in the urethra at 6 o'clock, inside to out, and then you go outside to in the bladder at 6 o'clock. Then you take 1 limb inside out on the urethra at maybe 7 and the other one at 5, and then you pull those out completely, and then you sort of continue one of them on one side till you reach 12, and you do the same thing on the other side with the other end of the suture.
Hi, I'm Dr. Amit Goel from Max Gurgaon. So
Hi, sir.
I'm not using Rocco stitch at all.
Catherine?
I do a double needle suturing. So two 15 centimeter sutures, we're taking 3O. And we start posteriorly, just complete the posterior plate. So we give 3 sutures both sides from the bladder to the urethra, and then cinch the needles from both sides just to complete the posterior plate. Then come either side circumferentially and then close it at the anteriorly. So, and no ROCO, no alas, nothing.
So what is the reason then for not doing a posterior reconstruction and anterior reconstruction? Is it because it takes time, or?
No, but we've found that the results are nothing different. So initially I used to do ROCO stitch, but we've stopped doing it totally, and the results, means continence wise or anyways, it's not a problem. So basically the advantage of using the ROCO was like when you're doing the urethrovesical anastomosis, that time you have in the bladder and the urethra closed. So the problem of getting cut through is definitely less. But I use a cinching technique, so once I start from the bladder side, come inside the mucosa, go from the urethra, and once 3 sutures are done, we just gently pull it one by one, both sides, cinch it, and this pull is from the bladder end towards the mucosa end of the bladder, and that is how the bladder keeps coming closer, and then the posterior plate gets closed.
So I was trying to doubly sure that it doesn't bleed, and it started bleeding because of the suture.
Sometimes the more sutures you put, the more bleeding
I could see a clot there, so I thought I'll just take the suture through it so it doesn't bleed later.
It's probably the right thing to do, I think, because you don't want it to be bleeding afterwards when the clot dislodges.
Yeah, just in continuation with the technique of suturing, Dr. Chandrakant this side. So like what I do is the same as Amit sir mentioned, but I use a monocryl 2O with a uro needle. That is a 5x8 circle needle. And the cinching technique, the same cinching technique, but with a monocryl, since it glides well, so the bladder cinches quite easily onto the urethra. Since I am doing it laparoscopic, so I find doing a ROCO stitch first becomes difficult for me to take those stitches because the bladder goes very close to the urethra. Maybe in robotic it is easy, but laparoscopically that is difficult.
And you're using a 0 degree scope, is it?
Yeah, 0.
So what I do is I use a 30 degree scope. We do it a flip. So one time it is, when I'm seeing the bladder, it is looking down, and when the suture is being taken on the urethra side, I tilt it upside towards the upside. So both the visions are excellent in that case.
Agreed. It's just that you'll have to flip every time.
That's what. Yeah. Sometimes it happens that, like your camera hasn't got a spot doing this. So when you're flipping, then a lot of times it happens that there's a blood stain on your camera.
This is annoying.
Can you swap the eye on the camera? I might do that for you. I got both.
Dr. Tushar, so when this happens, what we do is we put a small piece of Surgicel and over it suture it so that it tends to not bleed.
I'll put it. If it doesn't stop, I'll put.
It'll go off. It'll go off.
It's just beneath the bone, the veins of the bone. I'm taking this bites, I can feel the bone. Because the DVC is down here.
Tushar, just keep a gauze there and increase the pressure for 5 minutes. I think it will stop. There's no point, if you keep on suturing.
I'm hitting the bone and it's bleeding more.
Just leave it like that. It will stop. Pressure बढ़ा दो.
Leak test. Let's do the leak test. Final catheter in. Okay. $50 more. यहाँ suck कर लेना side में. 200 in. Perfect, looks okay. ठीक है. Okay, खाली कर दीजिए. इस पे एक क्लिप लगा देना, इसको काट देना. अरे को इसको ऐसे ही कर देते हैं, टूट ही जाएगा. खाली करना ब्लैडर. Let's see if it's stopped or not. लगाना. Yeah. Cut. Cut. Out. इसको मैं रोकता हूँ. प्रेशर कम कर देना. 8. Out. Okay. Now let's take care of this. 30 भी रेडी रखना अगर चाहिए होगा तो. ये बोन के नीचे से आ रहा है. हाँ अभी लेता हूँ. 1 मिनट रुक जाओ. एक बार पहले रोक लेता हूँ. हैं? अभी रुक जाएगा.
Tushar, I think you could just place a Surgicel and walk away. It's going to settle down on its own.
I won't be able to have a drink tonight if this doesn't settle down.
No. So you have then clearly not, you are not, I know you said before you were not doing open radical prostatectomy, right?
Yeah.
That's why you're not brave enough.
Pressure down to 8 please. 8 पे यहाँ सक करना. एक और सर्जिकल यहाँ के लिए देना. सर्जिकल या फिब्रिलर कुछ भी दे देना.
So Tushar, I think that is that area what Professor Mano was talking about.
Yeah.
So what I have started taking a small suture, a small PDS on a 3O or a 4O and just suturing that.
एक बार आई क्लीन करना मेरा. And let's see the hemostasis this side. Suck. हाँ एक बार सर्जिकल डाल दो फिर कैमरा क्लीन कर दो. यहाँ ठीक है. इधर तो सर्जिकल से ही कैमरा गंदा हुआ है. Okay. Quick camera clean, then port closure. Quick camera clean. हाँ मुझे याद है. देख लेता हूँ. There was one area where we had touched the artery with the cautery. एक बार उसको देख लेते हैं. कहाँ है? ये था क्या? तो फेशिया है. Where had we touched the artery? ये सो retract करना bladder को एक बारी. This. Does this need anything? I think it looks okay. Okay. Okay, that's fine. Okay.
Dr. Tushar, what is your opinion on just folding the bladder and keeping the peritoneum over it?
Hole in the bladder?
Folding. So now the bladder, the raw area is there.
Yeah.
What is your opinion on just folding over it?
It'll just get
just
stuck
to increase the, you'll tug it?
No, I won't put it back. I think when the pneumo goes down, this will come up and get stuck here.
Okay.
Would you close it? Would anyone close this?
So we tend to just fold it over.
Hold it over?
Yeah. No. Towards the pubis, towards the anastomosis.
Towards the pubis.
Generally
it
falls.
this.
Generally it falls.
Okay.
But I mean, just to increase the peritoneal surface over it.
Okay. So I think the only step now remaining is to close.
The concept behind that is when you do that, the lateral gutters will remain open. So you have that channel for lymph absorption. That is
so there is some oozing here. If this doesn't stop with bipolar, I'll take a suture.
So I don't drop the bladder. I leave the urachus intact, so I don't have that problem.
This is coming from here.
The odd instances that you do drop the bladder, you fold it
Yeah.
and suture it to the endopelvic fascia. This concept was by Vipul Patel and a European surgeon. It's been around for a long time. And they have, it was a small study of 25 from Miami and about 30 patients from somewhere in Europe. It was not statistically significant, but they saw less lymphocytes.
Okay, take it. Anywhere else?
You start doing it when the symptomatic lymphocele happens to you.
Chalo, Vesicle de do. अभी दे रहा हूँ fourth arm. Yeah, and doc, Vesicle please. Undocked fourth arm. Out. फोर्थ अनडॉक कर दिया है क्यों हिट कर रहा है फिर क्यों हिट कर रहा है प्रवीण पूरा फ्री होना चाहिए मेरा ये हाथ चलो हो गया क्लोज अंडर विजन गैस को दूसरे में लगाओ आउट close good perfect I think the hemostasis looks okay we will put a drain because it's a little oozy and we've done quite extensive lymph node dissection, so I generally put a drain if we do a lymph node dissection. And I think we'll undock now. Is that okay?
Yes, looks great.
Okay, perfect. I think any questions?
Thank you, Dr. Tushar. It was very good. The demonstration, we enjoyed it.
Perfect. So there were 2-3 mistakes which shouldn't have happened. The first one was while we were defatting the prostate. So there's a superficial dorsal vein which should be bipolared, and while bipolaring that, I touched the deep for DVC complex. Thankfully, it didn't bleed a lot, so it stopped. And the other was while doing the artery. So I do the lymph node dissection with 30 degree. I'm not very used to, 0 degree. I'm not used to 30 degree. That's why it was coming into my face, and that's the reason why. Even if you make a hole, nothing to worry. Just take a Prolene figure of 8 suture, and that you should be fine. So I think, sorry? Back दे दे रहा हूँ. I think rest of it was standard. The anastomosis and the Rocos was exactly how Ashwin did. So both the cases you saw the anastomosis being done in the same way. And we'll have recorded videos with the conversation put on YouTube, and we'll share the link with everyone so that you can go back and see. And this case, I did a bit of circumferential, but mostly I did the top-down approach, wherein we came in from the top. So you can see that. And circumferential, I would suggest do it once you've done about 20-25 bladder necks, and then go on to circumferential. Perfect. So we'll stop the transmission now. It's about 5:45. So let's head to Essex Farms, and we can have a discussion there over the different steps. And as it is, Ashwin will be presenting the steps of robotic prostatectomy and his talk on functional aspects of radical prostatectomy. And we have very interesting 3 panel discussions from Dr. Kinju, Dr. Madhav, and Dr. Rahul Jaina. So, and then we'll have dinner and drinks over there. So thank you everyone for joining us, and we look forward to seeing you at the evening function. Perfect, thank you. So we'll stop.